Good morning, everyone. Welcome to this AM Upskills webinar. I'm joined this morning by Dr. Uche. Hello, thank you for joining us.
Morning, or afternoon, I said maybe.
Oh yeah, sorry, it is afternoon now. So just while a few more people come in, this session is going to be all about treating the tear trough and the eye area, so indications and the options. I know Dr. Uche is mainly going to be focusing on filler and toxin, but there are some other modalities he's going to go into as well, and he's got some great before and after pictures to show you and a few case studies to talk through. So just while everyone comes in, do you want to give us like a brief introduction to yourself and to what we'll be talking about today?
Of course. Well, afternoon, everyone. My name is Dr. Uche Aniagwu. I'm commonly known as Dr. Uche, and I am the clinical lead and the founder of the Dr. Uche Tear Trough Training Academy. So I'm one of those really sad people who's decided to just focus on just one part of the face and make it my obsession, which is the eyes, the periorbital region and the infraorbital region. So today I'm going to try and make it as fun as possible to share with you guys on a very, very high level, nothing too deep, just kind of what kind of options you have when you're treating the area, the indications, the pros and the cons, and then look at some case studies to try and make it interesting. And I'm acutely aware that with these type of webinars that you can't speak back. So I may crack jokes. I'm going to imagine you guys are laughing, and I'm going to just keep it moving. So hopefully you guys enjoy today.
Wonderful, thank you. So if you just want to get your presentation ready, everyone watching, if you've got any questions for Dr. Uche, please do drop them in the chat box, and then I'll come back on at the end and we'll go through some Q&As. Okay, cool. I'm going to hide and mute myself, and then over to you, Uche.
Okay. Fantastic. I'm just getting this ready. Awesome. All right, guys. So once again, if anyone who's just joining now, welcome to this webinar I'm doing with the Aesthetic Medicine magazine. This is on non-surgical eye rejuvenation, and we're going to look at the indications and treatment options. So a little bit about me, for anyone who just missed my little spiel earlier. So my name is Dr. Uche Aniagwu. I go by Dr. Uche because saying Dr. Uche Aniagwu for most people can be a headache. So you can just call me Dr. Uche. I am the founder and the clinical lead at the Dr. Uche Tear Trough Training Academy. I'm also the founder of the Cosmetic Eye Clinic, which is based in Harvey Nichols' Beyond Medispa. I'm the author of the Essential Eye Beauty Guide, which I wrote to help people at home, so basically your clients or patients, whatever you call them, to find ways to manage their eye concerns ranging from dark circles to dry eyes. I've been on panels for Glam Magazine. I've written for Aesthetic Medicine, I'm Here Now, Aesthetic Journal, to name a few different platforms. And my Instagram is Dr. Uche Academy. You can see it there, at Dr. Uche Academy. And my website is, as you see below, www.druche.me. So that's enough shilling myself. And now to try and get to what we're going to be talking about today. So what is it you guys are going to gain today? What am I going to try and give you all? I'm going to put the pointer on because it really helps me. Okay, there's a pointer. Cool. So the first thing I want you guys to get today is a very high level, a broad overview of periorbital treatment options. So if someone walks in and they've got eye complaints in your clinic, what are you going to do? What are your options? What can you consider? And the next thing I want us to do is look at this on a case-based level. So look at faces, analyze the faces and go, what will we do with this face together, and decide what treatment option is going to be right for us. And the last thing I'm hoping you guys gain from this, most importantly, is a bit more confidence in selecting the treatment method that you can use to manage your patients in your clinics. Now, before we get started or into the sort of, the nitty-gritty science and the options, let's talk a little bit about why it's good that you're here and you made a smart move to join in today. Treating the under eye region, the infraorbital region, or periorbital for that matter, it's where things are going. And there's a lot of perception and there's a lot of reality differences, which I wanted to address very quickly. So first and foremost, I want us to look over at this side on the right-hand side of the slide. And you can see here that tear troughs is a second bar, and it's the second largest concern for young females, as it was in this study, and the third largest concern in the older females, so age 60 to 65. So whether you're on the younger side of 30 to 34 or the older side of 60 to 65, it's top 3 concern, which is pretty interesting because we can see lips all the way down here and jawline and cheeks all the way down here. But the problem is that it's not provided enough by practitioners. So there are a lot of different things, right? People think that as clinicians, as injectors, we think the area is dangerous to treat. Well, it's not that dangerous to treat compared to other places in the face. And we always think there's only one type of patient with the hollows in the eyes. Again, that's a lot of miseducation, which I always try and teach people that you can see way more patients if you have a sound understanding and education on how to manage the area. Okay, so it represents a massive financial opportunity for all of you if you get it right. Now, I'm not going to go into a lot of the depths and technique and that kind of stuff today, but at least by the end of today, you have an understanding of your options, and you can probably start thinking about seeing more patients. So what are the main modalities? What are your main options for treating the periorbital region? So I want you guys to imagine, when we're talking about the ways of treating the eye area or the options you have, it's a little bit like a boy band. It's like Take That. You've got Gary Barlow, probably fillers. You've got Robbie Williams, your Botox, and then the others are just kind of like backup singers. You don't really know. They're kind of, if you need them, they kind of add to the mix. But your main two are going to be the first two we're talking about. So you've got hyaluronic acid fillers. They are the things that will be the staple of your clinical practice for treating around the eyes. And you can use them to tackle sunken eyes, bags, even poor skin, depending on the type of filler you use. I've just got an example here. This is Tioxane. I'm not a brand ambassador, but it's just one example of a filler. Now, what are these fillers that you're using? They actually just simply sugar molecules that work through volumization. They add volume, right? They draw in water, they give volume, and that's how it works. Now, there is a lot. This whole area is called hygroscopy. Now, there's a lot around it. And when you're trying to pick the right filler for the under eyes, you've got to make sure you pick a filler that doesn't draw in too much water, because you'll be able to predict your results. And it's, even though it's not a dangerous area, it's still a, if you like, a tricky area if you're not aware of what to do. So what are the main pros of using fillers around the periorbital region or infraorbitally? Well, you can have multiple uses, like I've said here. You've got treating sunken eyes, you've got puffy eyes and bags, you've got poor skin. If you've got dark circles secondary to shadows, they can be helpful. Little dips and deformities, you can camouflage. So it's really, really useful. And your patients are going to know what fillers are. They all know. Every patient knows what fillers and Botox are. Like I said, it's your Gary Barlow and your Robbie Williams. And outside of that, you're not sure who the other members of Take That are. And also what's really important is reversibility. You have a chance to correct your work pretty instantaneously when you're using fillers, because if something goes wrong within a day, a week, a couple of weeks or a month, you can bring your patient back and you can reverse it using hyaluronidase. So it's a really, really good pro for using fillers. Now, some of the cons of fillers is that, like I said, especially around this region, probably more so than anywhere on the face, even though it's not that dangerous, it may require the most amount of skill that's worth investing in, because it will help you increase your bottom line dramatically, but it still requires a high technique level. And some of the reasons why is that you have a real risk of edema, that is swelling, because this can draw in water, as any filler can. And if you're not using the right product, or if you're placing it in the wrong place, you're going to get that dreaded swelling. It's probably most people's concern is, oh goodness, the complications after I've done fillers. And of course, with any filler, there's a risk of occlusion. So that's a risk that's going to be true anywhere in the face and with any filler that you use. So that's one of the cons, again, of using hyaluronic acid fillers. Now on to Botox. That's naughty of me. I should call it botulinum toxin, because that's what it actually is. Botox is simply the brand. Now, I love Botox. I always say, if I could go to a desert island and have one thing that I'd take with me, it would be Botox. And the reason why is that it's pretty straightforward to use. Now, around the eye area, you can use Botox anywhere you have crow's feet or periorbital wrinkles around the eyes in general. That could be slightly underneath, so slightly more, if you like, infraorbitally, so not quite crow's feet, and even a slightly more superiorly, where you start going up towards the eyebrow. And that can be used to do things like an eyebrow lift, you know, the fox eyebrow now, everyone's kind of, you know, raving about. I mean, I don't think it's anything new, it's got a new name, but we've been doing it for years. The fox eyebrows in fashion, you can use Botox to do that. You can use it to tackle hooded eyes. So some people have quite low set eyes naturally. And you know what, by using Botox, you can give them a bit more of a lift and actually can help stave off what will be progressively worse or heavier hooded eyes as they get older. So Botox has a lot of uses. And it simply works by causing what they call flaccid paralysis of the muscle, which very simply put means it relaxes the muscle and it can't contract as strongly as it would normally. So why do I love it? Like I said beginning, it's straightforward to administer, very easy to put into the face. You put it into superficial level or deep level, depending on where the muscle is. So it's not just superficial everywhere. Around the eyes, it's mainly superficial, but once you start looking towards the glabellar complex, there are parts of it, contrary to what people say, that should really be going deep. It doesn't add volume to your patient's face, and I love that. So it means that you can't technically change the structure of their face. And also, you tend to get fewer aesthetic complications. So things like migration, lumps and bumps, malar edema, the things that are associated with treating the infraorbital or periorbital region don't tend to get with using botulinum toxin. Now, the cons of it is that it's pretty hard to gauge the results, right? You don't see the results for a few days. So you're going to get a lot of comebacks or top-ups that you have to do, and your business model has to be ready to cater for that. You can't just see it and go, yeah, good result, off you go. It's pretty hard. And also, it's not reversible. So if you do happen to raise someone's eyebrow up a little bit too much, or you do happen to drop their eyebrows a little bit too much, whatever it may be, you've kind of got to ride out those effects. Well, not you, your patient has to ride out those effects. You've got to ride out the complaints. And that could take anything from weeks to months, because Botox tends to wear off at about 3 months. Although complications I see tend to wear off after about a few weeks, normally 3 to 4 weeks. Now we're coming on to the rest of the band, if you like. And now you've got topical treatments. So topical treatments are really important. And I would say they're really important for the patient more than they are for you, because patients, this is the only part of the treatment plan they get to have true control over, i.e. they get to do it themselves at home. So from that perspective, even though we sit down here and say, well, it's only part of the band, it's not one of the main two singers, actually for your patients, it's like this is their sense of control. They get to use it at home. So some of the options you may have could include retinols, vitamin C, peptides, to name a few. I mean, there's every company now, Zio, Lumiere, you name it, Delarom, they've all got their fancy, very efficacious, different ingredients that do work. A lot of them are BS, a lot of them don't work, but most of the companies that you can sort of vouch for, the reputable ones that are based and founded in science, they do work. And actually, it just kind of comes down to what you prefer and what you're trying to achieve. Now, that might include tackling puffiness. And I've said here diurnal puffiness, because diurnal puffiness is referring to the puffiness you get that fluctuates through the day. Is it worse in the morning and better in the evening? And if the answer is yes, then that says it's something to do normally with lymph drainage in the infraorbital region. And if that's the case, it means that you can use some of the fancier topical treatments that have like a metal applicator, which can help reduce the puffiness in the morning. If the patient says, I'm puffy all the time, then it might be that they have pretty advanced lymphatic compromise, or what you're actually seeing is fat prolapse. So infraorbital fat prolapse, and that's not going to be helped by any topical treatment. Also, skin elasticity is another one that you can help with. It can work well with Botox. Obviously, Botox helps reduce wrinkles and lines. It's more for your dynamic and static lines, but using these can also help improve skin quality. And then lastly, I think the big thing that topical treatments have a place for is hyperpigmentation. So being able to segregate and categorize, if you like, the reasons or your causes behind dark circles is crucial. Because if your dark circles are caused by hyperpigmentation, then actually you might want to lean on topical treatments and promote this one to one of the ones of note, if you like, from your modality class. Now, what's good about this is that you can do this, patients can do this at home, and there's not much of a risk profile, to be quite honest, besides skin irritation, which you should check for. But the negatives are that the results are pretty slow, and the actual ceiling for improvement may be lower if you use this as a sole treatment versus your fillers and your Botox. You got Mesotherapy next. I've got the brand here, Light Eyes. They're pretty impressive. Before lockdown, they came by and I saw them by and convinced my kids to start using it. They Mesotherapy simply means you're using injections of whatever concoction. It might be hyaluronic acid, peptides, plant extracts. You're putting it into the lower level, the dermis or subcutaneous fat. That's all it means. And it's like microneedling, just that microneedling is simply causing trauma as opposed to depositing something there. Now, mesotherapy is really good for improving skin quality, and it can be used for dark circles and improving circulation. Now, why would you consider using mesotherapy? Well, it can really represent a good adjunct to your others, so fillers and Botox. And it's pretty easy to administer. It's a bit like administering Botox, which I guess you could argue is a type of mesotherapy. Now, the sort of downside of it is that you get highly variable results, if I'm honest. Some people see a really good result, some people don't. With fillers, it's like you got what you got kind of thing. With Botox, someone comes back and says, oh, didn't really work for me, dose them a bit more, it works, they go away, they're happy. With mesotherapy, it can be a little bit more hit and miss. And also requires many sessions, which sometimes can be a little bit off-putting for the patient, but also tough on your schedule and how you manage your rota. But it can be a good adjunct and it can certainly help. Especially, I like to use mesotherapy when I'm looking at hyperpigmentation and dark circles that won't be, or I don't want to give a patient a topical treatment at home. They may consider using this instead. And if it's circulation focused, a lot of people have dark circles secondary to circulation issues. So they've got a little bit of blood pooling. Those people, yeah, I would consider mesotherapy as an adjunct to what I do for them. Okay, so now we're looking at radiofrequency. This is a very fancy way of treating the periorbital region. And to keep it very simple, it's an energy treatment which you can use normally for one or two things: skin tightening or fat shrinking. A lot of you may have already heard of things like Exilus, or Morpheus or Accutite. These are all different types of radiofrequency, which are basically applying some kind of like thermal heat energy to either cause damage to the collagen to tighten the skin or to shrink the adipose tissue, which is the fat tissue. Very effective, good lasting results, really, really effective. But the downside is that, one, these machines are expensive as hell for starters. I don't use them a lot in my practice, but they are quite expensive. Also, they do come with downtime, which is closer to surgery, if you like, not quite as extreme, but closer. And there are issues with skin color. So sometimes these energy treatments aren't best advised on people with darker skin color. So your Fitzpatrick 4, 5, and 6, because you don't know how the skin is going to react. You may get rebound hyperpigmentation. And so even though these are really good treatments, you probably won't lean on these a lot. And what I find is that people who sort of invest in these treatments make it their main thing. So radiofrequency can be a really good alternative if you've got access to it. And it can really help you. I think I look at it as a go-between your fillers and Botox and surgery. It's kind of like the step in between. So I think that's a good way to sort of think about it. All right, cool. So now we've gone over the, if you like, the main players, the options you have for managing the eye area. Now let's look at some cases and let's talk about what we would do or what I would do. I'm going to do some drawings as well. I'm not quite Vincent van Gogh, so if it sucks, forgive me. I'm going to do my best to try and draw a straight line where I can. Okay, cool. So let's get a pen. What color should we go with today? Let's go with red. Let's stick with a red pen. All right, cool. So this gentleman here on the left-hand side, I'm not going over like how old they are, their history and background. It's not the point of this presentation. Let's just look at what the problems are. Number one, boom, he has clear puffiness under the eyes, okay? And we don't know yet if it's because he has diurnal presentation or if it's just prolapse. I'm gonna say it's down to prolapse just to make life easier for us, all right? It's not puffiness due to lymph drainage, it's some fat prolapse he has there, so true bags under the eyes. Okay, now, he's also got some shadowing as well. So if I erase this, there's my eraser, all right, erase, good, it's working. It normally doesn't work during presentations. Okay, so Now you erase, you can actually see here as well. I'm just going to sort of this is, wish me luck, I'm drawing an arrow. Okay, here we go. So you can see here that framing the bags is actually a deep groove and some shadowing. He's got some discoloration, he's got some shadowing, got a deep groove there. So really what you can see is that he's got a pronounced tear trough groove and he's got puffiness and bags under the eyes. So how do you manage this patient? Now, typically you look at him and go, do you know what? Surgery, nothing to do with me. But actually you're probably going to send someone away who's going to go, I don't really want surgery because I haven't got the time to have time off, or I don't have to pay that money, or I don't have to go through that. And now you're not really helping them when you can actually help them and furthermore make it your patient. I'm going to tell you how. So first and foremost, simple things are first. And this isn't, like I said, this presentation is not here for you to go into techniques, but I want to just show you guys very briefly. Keep things geometrical, keep things sharp, and keep things, this is as much science as it is art. You need to be precise. So we want to go in here and we want to just fill like you would a straight line. We're not going all the way around. And I cover on my courses why we don't go all the way around and we fill, contrary to what a lot of people do. You want to keep it straight. Just use a little bit of filler here, just to, if you like, relieve the tension between the tear trough ligament and the skin, because that's a ligament that goes from bone to skin. Now that's going to help reduce the framing of the bags, but it's not going to treat the bags. Now, if you wanted to go one step further and you would really think about how can you really help this young gentleman, then you could consider using RF, so radio frequency, which we spoke about earlier. And that radio frequency can actually be used to help shrink the fat prolapse that he has under here, using something like Morpheus 8 or Accutide. So you have that option if you want to go that way. Topical products, I put a question mark because would you use a topical product here? If you felt like he had hyperpigmentation, then you could. I don't think he does. Actually, I'd be more inclined to use mesotherapy if I think he's got dark circles due to circulation than I would due to down to topical products. And if he had, let's say, puffiness that came and went morning and night, then actually I might use a topical product that's got a good applicator. But in this case, not so sure it's the case. So I'm looking at fillers as my primary thing, see how he feels before we even think about using radio frequency. Now I'm going to do something that's a bit new. I'm going to cheat. I'm going to show you guys what he looks like already. So look at that's his face. Oh, let's swing through. Here he is here. This is him. This is him. And you can see the difference in his eyes. And all I did was what I just described to you guys, by the way. I used fillers. I didn't use radio frequency on him. And actually, just by working in this region here, just by working in that region here, being very precise, I was able to get a good result. And you can see the difference between him here versus, let's swing back, versus here. So that's another example. That's a case for you guys. Right, now let's look at the next case. Perfect. So we've got a lady here who's got not bags under her eyes this time. She's got hollows, real clear hollows. You can see that. But she's also got some skin quality issues, as you can tell, and discoloration. So she's got reduced skin quality, she's got discoloration, she's got hollows, and then she's got wrinkles. We can see that. So what will we be thinking about in terms of helping her eye area? Now, first things first, will you guys jump up and say fillers? Again, these are things I like to cover in my courses, but you've got to be careful when you have poor skin quality. You've got to do this thing called a snap test, which basically checks the integrity of the skin, because if you use fillers and you have a poor or failed snap test, you are likely to get bad results. But that's a topic for another day. I will tell you now that her snap test was all right. And so fillers could definitely be used here to try and help in this region. Now, once again, I'm not going all the way around like so. Nope, I'm just going in here. We're going to fill here and fill here. And then actually, she's got some hollowness laterally here. So I'm going to fill a little bit using like droplet techniques in here. And astute people in the crowd or audience today will notice that I'm missing out this whole area. I'm going to put a cross. This whole area I'm leaving out. And the reason why I cover a bit more, like I said, in some of my other topics and courses, it's to do with the fact that you're likely to get issues, and it's all to do with the fact that you have a prezygomatic space in that region and blah, blah, blah. So what we have done, I will erase this to not cause any confusion, is I filled just those parts. So medially, here, and laterally some droplets. And that's filler. And that's going to give us a pretty good result. Now, we've also addressed skin quality, right? So what should you do? And I've actually been pretty naughty here, because truth be told is that I can help this lady because I know that her skin quality and her snap test, I've already told you, is okay. But if it wasn't okay, what would I do next? Well, I'm looking at, first and foremost, she's got loads of wrinkles, which I can help with. Botox, your toxins, whether that's Bocature, Botox, Dysport, whatever they're calling all the different names nowadays, you can use that in her crow's feet region. So I'll just draw that with a different color for you guys. This feels a little bit like Art Attack, so I apologize. For those of you who are old enough to know what Art Attack is. And here we go. So you can do a bit of Botox in this region here for her crow's feet, and that's going to help as well reduce her lines. But you can also give her a topical treatment, a topical product, because you can use that to help the entire area, if you like. So if you can help the skin quality of topical creams. You can also help with the discoloration by using mesotherapy. So I've actually been a little bit light on my options because mesotherapy might help her circulation. She hasn't really got hyperpigmentation as such. How do I know? Because you can tell her areas of hyperpigmentation because they're like freckles. Like here's one area of hyperpigmentation, for example. So you can see where those are. And then lastly, if you really were like, look, her skin quality is really poor and I want to do fillers on her because she's got really sunken eyes, but I can't, get into your radiofrequency. Go speak to another, offer her Exilis. Exilis is great for this, or whatever it may be, you know, your other options, InMode stuff. Tighten the skin, and once you tighten the skin, then you can work on the hollowness. In fact, that might be all she even wants and is very happy with it. So there are different ways in which you can approach it, but that will depend on your assessment. So a key point for you guys here is make sure your assessment is tight, because if your assessment is tight, you're going to know what order to do things in. So to really summarize for her, snap test okay, get in with the fillers, get in with the Botox. And for people who want to know, you can do Botox and fillers on the same day. It's absolutely fine. Just make sure you do your fillers first and your Botox second, so you're not massaging the Botox around the place. And then send her home with an eye cream. And if you think it's a bit more a bit more deep than that, or if it's a bit harder to solve, then start thinking about treat her radiofrequency. But that should come before fillers and Botox. That should be the first thing you think if you're going to go down that road. There we go. Okay, so let's look at the next case. In this case here, this young lady, I want to show you guys something here. So this is your tear trough, right? Your tear trough goes from the corner, your medial canthus, all the way until your mid-papillary line. At which point it becomes your mid-cheek groove. This is your zygomatic cutaneous ligament, which you can see here, which is continuing. So her eye complaint really, and you can see it really well on this side. If you look here, look. So you can see the swing, how that line goes all the way around through the cheek. It's two different ligaments, by the way, not the same ligament that's causing that. Now, she's also got a little bit of hyperpigmentation, probably been a little bit harsh. It's tiny, but like we said, she's got pronounced mid-cheek groove. So what do you do? So you can target the filler in this region, or the tear trough groove in this region, by using fillers, tiny amounts. We're talking like 0.1 probably for her, very tiny amounts. But what do you do about this here, this mid-cheek groove? Okay, so it works the same way. The zygomatic ligament attaches from bone to skin, just like the tear trough ligament. And what you want to do in this region is a little bit different, or it can be if you want. And this is one of the techniques that I've tried to pioneer. It's subcision, essentially. It's using acne scars. You can use it also with this. That means using your cannula. You should all be using the cannula, by the way, ditch the needle. Using your cannula, you should be able to get into the dermal planes here and actually cause separation and create some separation between the ligament and the skin. And that just lifts this ever so slightly to give an improvement, okay? Ever so slightly. And actually, if you want, you can use fillers in this region too, but you don't have to. So what I'm trying to expose you guys here to is alternatives to not just using your fillers, but also using your instruments, your actual tools to help you achieve the result, okay? So that's that part. And then if you want to work on her dark circles, then by all means, give her a topical treatment, whether it's your Lumiere, your Zeo, your Bargi, whatever you believe in. I would have shown you the before and after of her, but unfortunately, she hasn't given permission to show you guys the after just yet, but take my word for it, it works pretty well. We're going to move on to the next person. This lady here, I've actually treated half her face already. So this is the untreated side. I'm going to put across, and this is the treated side. And I wanted to show you guys that, so I wanted to demonstrate the two. So if you look on her left side, or so it's her right, but your left side over here where I'm circling right now, she has pronounced hollows. You can see that, okay? But she also has this like puffiness just here, very minimal puffiness. So you can't just go in gung-ho and start filling, because you're gonna make that worse. So what are you gonna do? She's got puffiness. She's also got some discoloration as well, right? She's got discoloration. Is it hyperpigmentation? Doesn't look like it. Looks like a circulation thing to me. You know, she's got prominent veins over here. I'll just highlight that here. She's got prominent veins over here. So it kind of speaks to circulation issues. So what are you going to do for this patient? Again, remember your main singers in the band, your Gary Barlows, your Beyoncés, they're the main singers. So always think about them first. So the first thing I'm thinking about is, can we use fillers? The answer is yes. Again, we're keeping a good technique and we're filling. And we're going in and we're going to fill here and we're going to just do droplets here. Okay, we're not doing any in this area. And you can see the difference between the two sides of the face straight away. And I will just rub that out just so I can, again, highlight that for you guys. The difference between treating, if I actually can rub them out. This is the awkward part. It's going to take forever. I'm going to have to do every single dot. Forgive me, guys. Okay, well, you get the picture. So you can see here that you can treat, and you can see the difference between the two sides of her face, right? The two different eyes, just by using fillers alone. Now, if I wanted to tackle some of her discoloration, then I may look at using mesotherapy. So we've got a mesotherapy appearance here. It's a rare sighting, but we've got a mesotherapy appearance here where I'm like, well, I've helped you here, but you've still got some discoloration. And I think it may be a circulation thing, maybe a little bit of hyperpigmentation. Do you know what? Let's use a little bit of mesotherapy if you like. Truth be told, she went home with both sides looking the same. You'd be glad to know I didn't just treat one side. And she was happy and didn't want anything else beyond this. Okay, so that's another example for you guys to see how you can use different modalities to help achieve the result. Okay, so I wanted to bring it back to some examples for you guys to see what the results you can achieve are. So you can see here in this patient here, you can see we spoke about her earlier, and this is what she looked like after having some fillers done alone. Didn't actually show the results after Botox, so I didn't get her back because she was so happy. And that's one of the problems you'll have if you're really good. People won't come back to see you. until 6 months later when they need a top up. You won't get the back in for photographs unless they want to top up. So I didn't get her back immediately afterwards, but she was very happy, and you can see the difference here by using fillers alone. Like I said, your lead singers are your lead singers. Botox, I did do Botox on her, so I'm sure her improvement was even greater. And yes, she's a constant or consistent Botox client as a result of that. We've shown you this gentleman already and the difference that we had in his face. And here's another lady here, another young lady with clear puffiness under the eyes. Again, you're going to look at this and say, surgery? Not necessarily. Again, lead singers are lead singers. Is it going to be Botox? Well, no, she's clearly young and doesn't have many lines or wrinkles. So think about fillers. And the answer for her here was I did do some fillers in her cheeks actually to support this. So cheeks and very small amounts going along the tear trough ligament, just a groove here to improve it. And then actually that led itself to this result, which was a massive improvement. You could probably be sitting down there and wondering now, thinking, what about radiofrequency? You're right. I could easily have done none of the above for her and simply have done some radiofrequency here. But tell you the truth, everybody likes a bit of cheeks. And there's a whole another topic that I get onto in my training courses about vectors and understanding how to tell if someone's got a positive or negative vector as to whether or not you treat the cheeks. In her case, she had a negative vector. We treated the cheeks, had a good result, and here you go. So those are some examples for you, just for you to think about in terms of how you can manage your patients and the options that are there for you. Okay, so in summary, your main modalities are going to be your fillers and your toxins. In reality, combination treatments will give you the best results, but of course, there are many limiting factors to that. Most normally, your patient's budget, okay? So you got to give them the best buck for their pound. So go with your main singers. And if you are going to go down the road of maximizing what you can get from eyes, which you should do, you're smart, you're here, because you probably realize we're moving to the mask era. Eye beauty is by far the fastest growing thing now. We're wearing masks in the industry. Invest in specialized training. I do different types of training. I don't do all types of eye training, so I don't do radio frequency and that kind of stuff, but invest in specialized training and you'll be able to make the most from just from all your patients and have a much wider variety of patients besides your sort of standard beauty patients. You get a whole lot of people who care about their eyes. Has a very different connotation. So maximize your resources by investing in your training and learning and shadowing and all sorts of things, and learning online, just watching videos and reading stuff. All right, so that's it from me. Spoken a lot. My Instagram, again, lots of stuff that's useful for you guys that you can see and watch that's on there, which I'd love to share because I'm a geek and I love sharing knowledge about this stuff. Questions and answers at this point, and thank you all for listening.
Wonderful, thank you, Uche, that was brilliant. I didn't have you down for a secret Take That fan.
Who's not a Take That fan? Come on.
A fun fact about you for everyone. No, thank you. That was a great presentation. We've had quite a few questions, so let's start going through them. Okay, first of all, okay, so with regards to radiofrequency, someone has asked, is rebound PIH not more, sorry, this, let me just, how this is worded. So rebound PIH, is that not more common in skin types 4, 5, and 6? And therefore, could you please explain why you said radiofrequency is better in those skin types?
No, okay, so if that's what you heard, I apologize. It's not better in those skin types. Radiofrequency in types 4, 5, and 6 comes with more issues, and that's one of the drawbacks. Now, there are many different types of things that you can use. If you speak to the company reps, they'll tell you, alter your energy, for example, right? Alter the energy that you deliver, or change your regimen, your treatment regimen, so it's further gaps in between treatments. But actually, once you start creeping up to 4, 5, and 6, you have more risk of PIH, rebound PIH, with radiofrequency. So you have to be pretty careful. If you're using something like Accutite, which is a heat thermal applier, so it's an RF, but it's actually underneath the skin into the fat itself, using that gives you a little bit more freedom. So depending on the options you have a bit more freedom with using RF to treat fat pads. But you need a whole mini surgical setup, CQC premise to be able to use Accutite in the first place. It's not too far off a surgery or surgical procedure. But for the handheld ones, your Exilises, your Morpheuses, you can still use them on people of color, 4, 5, and 6, but you've got to be a lot more careful. So you're correct in your thinking. You've got a greater risk as you progress up the darker skin scale on the Fitzpatrick scale.
Cool, thank you. Okay, now, okay, so I think someone just wanted to point out that with dark circles, they've said this may be an indication of low iron, if not hereditary, and that's important to notice, but they've said, thank you, love the session. So is that something that you will also look into in your consultation process with dark circles?
Absolutely. So if somebody's got a low iron, and that you can ascertain that from the history. So one of the things we haven't gone on today is really about assessment. And assessment is the key pillar to anything you're going to get right in your planning. You got to ask the questions. No different. You can't just have the patient walk in and say, I want this. You can. Some people operate like that. But if you want to be able to give them the best possible, you want to find out. If the patient says, look, I have a low iron traditionally, or I'm a vegetarian and I don't take iron supplements, then of course that could also be the cause of dark circles. If the dark circles are hereditary, then I like to think of that as hereditary doesn't really tell me anything. It just tells you the mode by which you have the problem. Is it hereditary hyperpigmentation? Because then that's different, because you have pigmentation issues that are hereditary. So your dark circles that are pigmentation linked and low iron linked are utterly different. And how you manage those is different. One is go get some iron, and the other ones we need to calm down the tyrosine, whatever enzymes that we have, inhibitors, and start breaking down that melanin, or it could be secondary to pregnancy. So you're very right. Do your assessment correctly, and that's going to dictate which way you swing in terms of your plan.
Cool, thank you. So we've had one or two questions about PRP in the eye area. So someone's just asked, what are your thoughts on PRP in the eye area? And then someone else has really similarly, just said, would you say PRP or PRF instead of meso?
So funnily enough, PRP and PRF in the eye area, they're not something I do a lot of. I actually don't do them. So I don't tend to speak on things I don't do. I have considered it before, and I think that everything has its merits. They can work. I've seen some people get some pretty good results in it. And actually, I've seen PRP and PRF being used in both ways. I've seen them used in deeper planes, and I've seen them used as a meso themselves. So when we talk about meso, it's really just a technique. What you put in it and what the meso contains is a separating factor. It's what's the important thing. So PRP, PRF, yes, they're going to be advocates for it. They're going to be people who say it's good. I don't want to condemn it, or I'm not going to sort of big it up and praise it because I don't use it myself. I've just never felt the need to use it. But for some people who already are using it for parts of the face, it can make logical sense and there's merit to it.
Cool. Okay. And a few questions about topicals as well. So what someone's asked specifically, which cream do you use for the under eye area with retinol? And then another one, well, more broadly, but someone's asking just kind of what topical products you would recommend. So what do you use in clinic?
Cool. So Zio had Hydroferm. It now goes by the name of, I think it's now called Zio Eye Brightening Cream or Intense Eye Brightening Cream, something like that. Changed its name like in the last year. That's a really good one. And it contains 0.1% retinol. It also contains kojic acid, which is a product that you get from fungus, which can also lighten hyperpigmentation. So when you have melanin issues or high melanin, which is the hyperpigmentation, then you need to consider not just breaking down the melanin, but also, if you like, speeding up the cell turnover and the skin turnover in the region. But anything that's above a 0.1% dose of retinol, please do not use it around the eyes because it will cause real skin irritation and damage. So you're going to use very, very low concentrations. So that's one of my go-tos. It's not my only go-to because you have other things that can also give lightening. Berry extract, papaya extract. There are a whole host of different things, like I said, kojic acid, that can all cause skin lightening and help with regards to that if you don't want to go down a retinol route, because not everyone's going to tolerate it. And I think the other question was, what eye stuff do I use in general? My go-to brands for eye stuff are Zio and Delarom and Teoxane. Depending on what I'm trying to tackle, with like Zio stuff, pigmentation. With Delarom, I love them for just general skin care and that kind of stuff. And Teoxane, I use them because I've got their Redensity metal applicator, which I love because it helps. It's cool, it's metal, and it really gives you a massage and helps stimulate clearance of lymphatic fluid. So if you're a puffy eye person, that's your product.
Cool, thank you. And someone's just added, said, I think it is Zio Intense Eye Repair that has retinol.
There we go. Thank you very much. Thanks for reminding me.
Yeah, cool.
Previously Hydroferm. I'm old school. I'm one of those people who's going to keep calling things how they are.
Okay, cool. We have loads of questions, so I hope you've got time.
Let's go for it.
Okay, cool. Let's see the next one. Okay, so someone said, great talk, really liked how you took us through different case scenarios. What eye issues do you find you encounter most in the 45 plus age group?
45 plus age group, their biggest eye issues are going to be two things. One, sorry about the sounds. One, wrinkles and lines around the eyes. That's going to be Botox managed. Number two is going to be, you're going to be careful. It's going to be, I call it sagginess, quote unquote. But that sagginess can sometimes be due to lax skin and sometimes due to actual fat prolapse, so bags. And how you manage that is completely different. So the Botox you can manage pretty easily. That's the most common. The second one, that's going to be down to your assessment. How are you assessing your patient? And are they always going to be surgical patients or not? And I can honestly say that actually, as you start to get older and older and older and older, the funny thing is that they probably might lean more and more and more towards your surgical patients. That doesn't necessarily mean that the 40 to 45 group are that. They're not that old. They're still pretty young. But that's what you'll tend to see. And it's also a thing of bearing in mind that 40 to 45-year-olds are not actually the millennial generation. They're just outside the millennial generation. They're Generation X. And Generation X, they look at fillers like, like, you know, they have a different relationship with fillers. They're far more comfortable with Botox. And so even if you offer them fillers, a lot of them will be like, no, you know, fillers are far more millennial generation, sort of 40 downwards. So yeah, I hope that answers your question.
Fab, thank you. Okay. So what's your preferred meso product for dark circles? You used a picture of one in there, didn't you?
Yes, the one that I use there, Light Eyes.
Light Eyes, cool.
Swedish company.
Fab. I've not heard of them. I'll have to look into them. Someone's asked, do you consider resurfacing? And that's all they've said, and it's a question from Facebook. So if that person's still watching, maybe you could expand a little bit. I'm guessing they mean just any kind of skin resurfacing under the eye area before treatment.
The answer to that question is, do I consider it? No, I don't provide CO2 resurfacing. Does that mean it should be considered? Yeah, well, doesn't mean it shouldn't be considered. So I don't consider it, but it should be considered. My very good friend, surgeon Tamer Shahid, I know we had a talk on my Instagram recently, and he does that. So you're right. If you're having skin issues and skin laxity, then resurfacing with CO2 laser is fine. You just got to be prepared for the downtime, and you've got to be prepared to know that it excludes. That really does exclude your dark skin patients. There are ways around that, preparing the skin if you're going to do resurfacing for dark skin patients, but it's a tricky game. But I don't personally do it. You will be able to serve 90% of the patients with what I've sort of spoken about today, maybe even 95% of the patients. Maybe 90, because the rest of them will probably be surgical. But between what I've said today and surgery, you might cover most. And there'll be a very small group who you might look to use CO2. But if you're already using it in your practice, if you've already invested in it, then absolutely correct. You're right to consider it.
Wicked. Thank you. Okay. Is there anything that of Fitzpatrick 2 Greek origin, 39-year-old has had dark circles all their life? The darkness has increased over the last years. If that was your patient, what would your approach be?
So with the increase in dark circles, I'm going to make the assumption that it's due to hyperpigmentation. I always want to start off with the lightest thing possible. So you've got to have a conversation with the patient and find out what they've tried. If they've tried all the topicals under the sun, then there's no point in me recommending topicals to them to go at home and try. If they haven't, then I would put them on, hydrotherm, or sorry, what the new name for the Zeo hydrotherm is. I would consider that, or I'd consider even looking at things like mesotherapy, something that they can do light touch. However, if they've tried those things and it hasn't worked, or they don't necessarily have the patience for it, or it's really, really, really bad, and I can see from assessment this is really bad, then of course you might want to then go on and consider even pushing them forward to someone else. I don't have a CO2 resurfacing resource that I give my patients, but you can use it for that, because that can actually help if the pigmentation is in the superficial levels. And one of the ways you can tell if the melanin or pigmentation is superficial is stretch the skin. And when you stretch the skin, if it actually lightens when you stretch it, that means the melanin's in the epidermis. If it doesn't lighten when you stretch it, like when you have melasma with pregnancy, it means it's in the dermis. So if it's in the epidermis and lightens, then you might be able to do CO2 resurfacing and actually get that as a better result for them. But if it's me, which is what you asked me, I'm going to try and figure out what they've had done, and I'm going to be thinking about, can I go topicals and can I go mesotherapy? Because those are your true things that are really going to target hyperpigmentation from most clinics.
Cool. Okay, next question. What about Synicos for under eyes? Have you tried it, and what are your thoughts?
I've not tried Synicos, and so I'm sort of loath to express my thoughts in it. Even under eye guys, people, disclaimer, I don't use everything on the market. I tend to use what works, and I'm used to. But I would say, check it out. I think what I can say is, when you're trying to pick a product that you're going to use, and this might rub people up the wrong way, what I'm about to say. It's all well and good when the reps bring you a product and they say, hey, look, this product works, look at the results. But two things really matter, and I look for. It's like if you're about to pick someone to coach your football team. You want to not only hear what they have to say when you see the interview and see the numbers, right? But you want to be able to go back and look at evidence. So that's what other research in the before and after is showing. And almost of absolute importance, what's the track record like and the history? So I don't actually tend to use anything that's been in circulation for less than a couple of years. And I don't know about the product you're talking about now, and it may have been around for a while. I'm not sure if it's been around for a long time. I've heard of it, but not used it. But that's my selection criteria. So for those of you who are like, what do I pick? And if I hear all these new things, what do I go for? Look for the ones that have got a long history. And the reason why is that you don't want to be the guinea pig or the first one when things start going wrong, or there is a new understanding 12 months later. We've seen that happen with certain fillers on the market that everyone jumped on and didn't have a CE marking, and now they do, but we realized that things weren't quite as good as we thought they were going to be. And so that's what I would say. It doesn't quite answer your question, but I guess it's a nugget that I can drop for all of you guys who are thinking about trying out something new. So apologies, I can't answer it, but I don't know enough about it, so I can't speak on it.
Cool, that's a good answer, thank you. You might have a similar answer for this, but someone's asked, can you comment on fat grafting for under the eyes?
Okay, again, I know a little bit more about fat grafting under the eyes, so I'll say this. Fat grafting under the eyes, and we're speaking about people. So for those of you who are wondering, if people have really sunken eyes and hollows and you want to use an alternative to fillers, you can use fat grafting. Fat grafting under the eyes, I'm not going to speak on how easy or hard it is, because it depends on your aptitude to do it and your skill level, or if you offer it or a partner that offers it. There are many different aspects at any time you're using fat grafts, so, autologous fat grafting. Yes, it gives you a more permanent fix versus fillers, but there are, sometimes fat tissue acts in weird ways. It hypertrophies, it atrophies, and so you may not get necessarily an even distribution. It may not come out exactly how you plan it, and you lose the sense of control and reversibility that you have with fillers, and that's the trade-off. In exchange for a more permanent result, you have a little bit more variability, and less, let me rephrase that, you have less control. Whereas with fat fillers, yes, fat grafting under the eyes, I've seen it, I've had patients who've had it, I've managed a lot of patients who did it, and I used to work in a clinic where we did a lot of surgery. We didn't do fat grafting, but we had a lot of patients along those lines within our clinic. There was a plastic surgery unit, and actually, truth be told, is that whilst it's very good, you've just got to be aware that fat acts weird. It gets hard, it gets lumpy, it atrophies and dies. You can't always predict it, but it is an option. And some patients would rather have that than come back and continually spend money having their fillers done with, or their under eyes done with dermal fillers.
Great, thank you. Okay, next question is, how often do you use toxin in the infraorbital area, and when would you opt for toxin rather than fillers?
Okay, so in the infraorbital area, okay, how can I answer this best? I use toxin rarely in the infraorbital area. I use it a lot in the periorbital area. So if we're talking about like the canthus, so the sides of the eyes, let me flip back. I think you can all still see my screen. I'm going to flip back here. So for example, let me just demonstrate this with a pen. I forgot I had this here the whole time. Right, so like here, 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 like anywhere from here to here, I would happily use, and obviously we're going to be working in these, this is all periorbitals as well, right? So all here too, and all here, right? They're going to better complex. Now, I'll use Botox in these regions very happily. When you start going under here, I use it a little bit less, because actually I think mesotherapy serves a better role there. And I know a lot of people started doing Botox around here, and it's very cool. I'm just pretty careful about that, because if you hit the zygomatic major muscle, you can form what people call a ledge. And actually that ledge forms and it looks a bit weird, and the patient will not be happy and will be there for a while. So that's, I don't use it a lot. And I'm trying to remember, what was the second part of that question? Sorry,
no, that's fine. The second part of the question is, when would you opt for toxin over filler in that area?
Cool. So I'd opt for toxin over filler if, number one, anything above here, right? So above like sort of this region, this is a really terrible line. Let's try this again. So anything above here, so the upper part of the eye region, so basically here to here, right? This region, when you're using fillers, can be done easily, but it carries a lot of risk. So when you hear about blindness, A lot of the vessels that feed into the optical artery, ophthalmic artery, and lead to the back of the eye, to the retina, they all come like through here. So this is like, you can do it, but it's blindness central. So actually anything above here, I'm very reluctant to use fillers for, to treat the lines, because you're right, you can use fillers to manage wrinkles and lines, but anything above here, I tend to use Botox for. Furthermore, if somebody hasn't got any structural deficiency, and actually all they have is lines, then I will use Botox. I prefer to use fillers if I see a clear gap, or it's something that I need to camouflage. If they have a clear lump or bump or clear edema, then I'm thinking to myself, well, you've got clear edema here. Can I camouflage this with fillers? So that's when I use fillers. But otherwise, upper part of the face, Botox. No structural deficiencies, anything that needs camouflaging, Botox.
Cool.
Sorry, toxics. I should stop promoting Botox like that. It's not fair to Botox or the rest of them.
Cool, thank you. Can you just please mention one more time what mesotherapy you use?
Of course, light eyes.
Light eyes.
So light eyes are they're my go-to.
Cool. Sorry, are you all right for time? Because we've still got a few more questions.
That's fine. Let's go for it.
Cool. Okay, let's see. Okay, let me do some of these from this chat box. We've done that one. Okay, so how do you assess whether someone needs medial cheek filler first before teardrop filler?
You asked me to give me my secrets. The answer is you have to assess them using the vector methodology. And assessing vectors is a bit complicated. If you guys go onto my Instagram page and go on the link in my bio, there is a free course there. It's a very short course, but it's a free course. Click that link, register to it. I talk about vectors in that. And the answer is pretty simple. Vector negative, think about treating the medial cheeks. Vector positive, you may not need to treat the medial cheeks at all, and you can look just at treating the infraorbital region or teardrop region.
I'm just going to pop your Instagram in for everyone. Is it the Academy one?
Yes, that's right. So Dr. Uche Academy.
Cool. I'm going to pop that in so people can see. And someone's also asked about whether you could elaborate more on the positive and negative vectors. So is that also within that short course?
It is, yeah. So it's in that short course. You guys will see that there. It talks about what the vectors, negative and positive vector is, and it's all geometry. Treating the eyes is geometry. It's mathematics. Once you there is a little bit of fine art to it, don't get me wrong, but once you understand the maths of it, you can pretty much replicate the result every single time. And then once you understand the anatomy, the maths gets you good results, the anatomy avoids you complications. That's how you think of the eye area. The maths gets you good results, the anatomy avoids your complications. And by complications, I don't just mean blindness, I mean you're coming back and complaining, oh, I've got some swelling, oh, I've got some puffiness, oh, I've got some lumps. Any of that stuff, complaints and complications, you solve by knowing your anatomy.
Cool, good advice. Okay, so can you please go back to patient number 3? Someone's asked about...
Swap this out.
Okay, so do you think injecting filler in the cheek would address the volume loss in the malar groove and help with the tear trough in this case?
The answer is no. So back in the day, before I started figuring stuff out for myself, I used to just go ahead and treat cheeks. And the reason why I say the answer is no is twofold. Number one, you may get results where you treat someone's cheeks and they have volume loss in their cheeks, real volume loss, and you get a good result and you think, well, hey, this is great, but it's not the answer. Reason why it's not the answer is that the problem that you're solving is an attachment between ligament and skin. That's number one. And number two, I'm going to give you guys a little thing here. A few years ago, when I thought I was a hot shot, I had this really cool eye day, ran it like I was running some kind of Vogue model shoot, had tons of people down there, loads of really young, beautiful ladies there. And they came in and they had, some of them had this, you know, the mid-cheek groove, but they had really good cheek volume. Now, what do? Do you stick filler into their cheeks when they got good volume and give them hamster cheeks? Of course not. So you have to have a scalable or replicable way of managing this. And the answer is you've just got to treat the problem. And if you just treat the problem, which is the attachment between ligament and skin, not only do you give yourself the room to say, if the person's got good cheeks, I can treat them anyway, but also you don't have the variability of, oh, well, if they've got cheek volume loss and I just go ahead and fill the cheeks, I may get a good result or I may not. You've got to think about the problem. And so I encourage everyone, look at the anatomy. What is the anatomical foundation of what you're trying to do? And then if you understand the anatomical foundation, you can start being creative in how you manage the problem. Remember, going down to bone and giving volume with your voluma or your ultra deep down to bone is replicating bone volume loss and deep fat loss. This is not a problem of bone volume loss. So that's how you got to think.
Fab. Okay. What is the snap test is the next question.
Okay, so I wonder if you guys can see me. If you pull really tight under my eyes on the skin and I let go of that skin, well, don't pull it that tight, guys. You're not trying to get the patient to jump off the chair. But if you pull tight in the skin and you hold it for like 5 seconds and you release it, that skin should recoil in 2 seconds. Now, if that skin recoils in 4, 5 seconds, it means that they've got less than optimal elasticity of the skin, be that elastin or collagen. That's your snap test. It's that simple. Alternatively, if you don't like pinching people because you're really an empath and you don't inflict pain, which you shouldn't really be injecting people if that's how you feel. But if that's what you are, hold down the swell like I'm doing now. It looks a bit weird. You can see it. And then release. And the skin should recoil again in 2 seconds or less. It's a very similar premise to the capillary refill test, for example. 2 seconds, see a recoil. If you've got a recoil 3 seconds or more, then you know that you've got some compromised skin elasticity. And there is your snap test.
Oh, thank you. Okay, last question, and then I'm going to let you go. So someone has asked again about PRP, but in the context of plasma filler. So they've said there's a lot of noise around plasma filler, i.e. using PRP in a gel-like form. You may or may not have used, but in principle, based on your experience, can you see scope for this as an alternative to fillers for the tear trough area?
Well, actually, funnily enough, here's the thing. PRP and its very foundation, you're taking the products of your plasma. And these things they're not water, they're not designed to hold water per se. They're designed to encourage, if you like, the extracellular matrix that produces more collagen, which I accept by default, and produces, GAGs, glycosaminoglycans, by default should encourage more water being held, accepted, but you've got to think about the primary use. What are you trying to recreate? And with PRP and PRF, fibroblasts, those type of things there, you're looking to recreate that extracellular matrix type of environment, which is very collagen rich, which is elastin rich, which is great for things such as skin. Now, as a volumizer, of course, it's going to have some use because, like I said, part of that matrix can actually draw in water volume. But the difference between that and hyaluronic acid fillers is that HA fillers, they got one sole purpose, or maybe a few others, but they're one main purpose. And that main purpose is to draw in volume. It's to provide volume and provide rigidity. And so to answer your question, if they develop plasma-rich PRP or PRF, and it has a gel-like substance, and they can start to look at the rheology, because now we've got to think about how expansive is it, how durable is it, what's the tensile strength, is it elastic, X, Y, Z, G primes, and so on and so forth. If you start thinking about that, then yeah, maybe you can get there one day. But if you remember that hyaluronic acid fillers have a sole purpose of volume. So one, they can draw in water, but if you get ones that don't draw in a lot of water, like you want under the eyes, you're looking at the qualities. How resistant is it? What's the gel-like spread? And so on and so forth. It's got a pure focus on improving volume in the area, predictably, which is important. Predictable volume, not unpredictable volume, because that's a pain in the ass. You don't know what you're going to get 2 weeks down the line. So to answer your question in summary, yes, I'm not a big vendor of PRP or PRF. I don't really use it, but is there scope for it? Of course, there's scope for it. Some people are going to swear by it. Will it ever, in my mind, overtake HA fillers? Probably not, because hyaluronic acid fillers will develop at the same rate, and probably just always be better served for that sole focus.
Cool, thank you. Well, that has been great. There's been so much good feedback. People saying it's been really informative and they've learned a lot.
Awesome.
So thank you, that was wicked.
I'm glad you guys said that.
I popped I popped Dr. Uche's Instagram and website in the chat if you guys want to have a look and maybe do that free little mini course. And then if anyone has any more questions, would you like people to DM you? Should they email me and I can pass them on? What's the best?
Yeah, drop me a DM, slide in my DMs and ask me whatever you want to ask me. It's absolutely fine. I'm always happy to ask questions. Like I said, I'm a big nerd when it comes to this stuff. This is what I love. So I will tell you where I can. And if I don't know the answer, I'll tell you straight up and I'll push you to someone who I know knows.
Cool. Well, thank you so much, Uche. That was wicked. We've been on for nearly an hour and people were still asking us questions. So good job. Thank you so much, everyone, for watching. And we will be back with our next AM Upskills webinar soon. And have a good afternoon, everyone.
Amazing. Bye-bye. Thank you. Bye-bye.
Bye. Bye.